every time I talk to a doctor about peripheral neuropathy, it's like, oh, I'm not getting the results I'm looking for, yada, 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 that same song and dance. And I go, okay, well, what is it? Tell me what it is that makes a neuron thrive, not just survive, but thrive. Okay. And they're like, what in the world are you talking about? And then I'm like, okay, well, okay, you don't know that answer. So if I were to ask you to draw the neurological pathway from your foot to your brain, could you do that? And they're like, Doc, I got to be honest with you, I can't. And can you tell me the three arteries that actually control the blood supply to your foot? And do you know how to test that? And some people know how to test it. We're going to go through that today, but they don't know how to explain that. And see, when we're using this accelerated growth factor, which we're going to talk about today, it actually helps activate your mesenchymal stem cells. It actually helps with angiogenesis to get new blood flow, new blood vessels. And again, if you have cold hands and cold feet, there's absolutely no way that these tissues can heal because everything or virtually everything that's needed to heal your body is actually in the blood. Okay. You're not getting nutrients to the dead tissue or the dying tissue. You're not getting oxygen. You're not getting vitamins and minerals. You're not getting hormones. So you're not getting the actual and white blood cells. You're not getting all of that to the periphery. Okay. So let's go through with how does a neuron not just survive, but how does it thrive? Okay. So this is a neuron and we've got to have oxygen. Okay. How do we test oxygen? Number one is through anemia. And we're going to talk about that today here in just a little bit. There are several different ways we can do that. Glucose. Your glucose should be between 85 and 99. And your A1C needs to be below 5.3. Stimulation. And when I do an exam on somebody, the neurological exam, I've been doing it for so long, it's pretty easy, but I carry a diplomate and a fellowship in functional neurology. It took me 6 years to get both of those after chiropractic school, and that was through the Carrick Institute. And so what we do from a 7-point brain, body, gut exam is we want to find out which neurological pathways are deficient. Today we're going to be talking about neuropathy, so problem with the feet. And then we have to figure out ways to stimulate it. And one of the things that we're going to stimulate it to activate these growth factors and mesenchymal stem cells and angiogenesis is through the accelerated growth factors that we're going to be talking about through PRP. And then also we have to decrease inflammation. So see, right out of the gate here, what I see when I talk to doctors is they're terrible at managing the patient's expectations because the doctor doesn't know, I'm going to be nice here, squat about functional neurology. It's like, oh, here's a great niche. Let's do neuropathy. Don't really know anything about it. Let's just plug and play this protocol. And then what happens when, you don't, the protocol is not working according to what you think working is. And we'll explain that. Now, this inflammation is A, E, I, O, and F, U. All right. So what happens if you're actually seeing a neuropathy patient and they have autoimmune disorders? How would you know that? Well, I'm going to give you a number today that contacts Cyrex because guess what? If you're going to play it, you are going to have to know how to read blood work. And if you don't know how to do it right now, no big deal. And you can call me up and I can on how to do that. What if somebody has an autoimmune disorder to their myelin sheath? Would you might not want to know about that? And the gangliosides, would you not want to know about that? Because these are autoimmune disorders that can attack white matter in your brain and in your peripheral nervous system for your myelin sheaths. Environmental toxins, we're not going to talk about that much today because that can be a problem. Infections, a little bit advanced, oxidative stress. So are we looking at inflammation at all? Are we looking at anything that can help us with oxidative stress? And we're going to talk about today, not just with accelerated growth factors, but this push patch program that we have for NAD which is going to help the body mitochondria and the body heal. So see, again, it's not going to be just one thing we're going to do. There are going to be multiple things that we're going to do to actually help maximize this person's recovery. The food that you eat. Have you actually done a test to see if a person had gluten sensitivity? Okay, celiac, malabsorption, and do they have any cross reaction with casein? And if you're telling me, no, you don't run these tests, I'm going to ask you, what are you doing? Why are you seeing these patients with these complex neurological disorders that, write this down, are multifaceted, right? Multifaceted, meaning there's multiple things in most situations that's causing this person to have neuropathy, and it's completely, trying to be nice here, completely idiotic to think that you're going to do one thing to a multifaceted health problem and solve that. I'm not saying that you can't get a honeymoon, but I'm not looking for a honeymoon effect where we feel good temporarily. I'm looking for a long-term solution. Now, in my clinic, I actually charge $15,961 for a peripheral neuropathy. Okay, right now, today is the 18th of the month, and we're at over $94,000 in collection. Good, bad, or indifference is. I'm just letting you know where I am. So I think at some level, I have the ability to show you. I know how to market. I know how to communicate. In our marketing, communication, metabolic care, and actually regenerative care. Now we have a medical doctor that's in our regenerative medicine department. She comes in twice a month to do the injections. I don't do the injections. It's not in my scope of practice, but everything else is, from doing an exam and then shuttling them off to her to do the injections, and then we do all the therapy in the clinic and at home. So the problem is that you don't know how to market, more than likely. You don't know how to communicate effectively because you don't understand. This is just the basic stuff here. We hadn't even dove deep yet. I've only got an hour or so there's only so far you can dive in 1 hour. But like with food, the food that you eat, are you recommending or telling people not, hey, I think you need to stop eating gluten and fast food. You need to stop eating that. This is destroying your life. Okay, but the thing is, you can't be doing these things and actually coaching people. Okay, you can't be out eating crap and you barely able to function as a human being and telling other individuals, here's how you need to lead your life. Okay, and then so when we have this autoimmune disorder, environmental toxins, we have infections, we have oxidative stress, we have our food supply, the person's eating unhealthy, the standard American diet. This is going to uncouple the mitochondria, and then this person is going to have some type of failure with the mitochondrial function. And so what we have here, again, we're going to have to go back to some very simple things to explain when we start doing the neurological exam, the 7-point exam. Why is this person, when we do vibration, why does this person, when we sense that, it's like, wow, doc, that actually feels greater than, the sensation in my sternum, or it feels less than the sensation in my sternum. So we have this, what is called the resting membrane potential, negative 75 millivolts. All right, the threshold usually that a neuron is going to fire is somewhere around negative 55, so it becomes more positive. Now, when we have this decreased oxygen, glucose stimulation, not enough stimulation, and then increased inflammation, the mitochondria is not going to produce adequate ATP, which means we're not going to have the appropriate energy in the body to actually function at its peak level. Now, what does this mean? We have what is called the sodium-potassium pump. This sodium-potassium pump, the inside the cell, and this is in neurons, is negative 75 millivolts. So with sodium, it's actually attracted to that. So we have to have this sodium-potassium pump to actually pump sodium out of the cell. Okay. And when we don't have the appropriate mitochondria, see, this sodium keeps going into the cell and it's raising this resting membrane potential. And let's say here now we have a resting membrane potential of 65. Now, what this means is the neuron is fatigued and it's easier to fire. And what we mean by easier to fire Give me just a second here. What we mean by easier, when we talk about it's easier to fire, it means it's when you do your tuning, if you should have a tuning fork that's 128 hertz. This is the Meltex. So we're going to activate it, put it on a person's sternum. We're going to test their thumbs and we're going to test their toes. Now, what will happen is patients will come in with neuropathy, and then we put this tuning fork on their sternum, which is our baseline, and we go, just keep it simple. We're going to go to the toes, and they go, wow, doc, this feels like a 12. Okay. And you go, wow, how can that happen? Because when patients have neuropathy, I thought they had loss of function. Well, that can happen down the road. But what will happen at the beginning is where actually this neuron is going to get closer to the threshold and it's going to fire. Now, when we get into a chronic health problem, of course, then this neuron fires is further away from threshold, and we put the tuning fork on the sternum and say, this is a 10. We put it on their toes, and they're like, wow, that feels like a 6, let's just say. So we've lost 40% function. And see, now we have to know, how do we manage the patient's expectations with this? Okay, so just going over some from some basic neuron theory is that neurons require oxygen, glucose stimulation, and decrease inflammation. If we lose any one of these, this is going to cause our neurons to malfunction. Inside of our neurons, we have this mitochondria. We want to produce ATP, and this is going to produce endurance. And this endurance is going to allow for neuroplasticity, regeneration, growth, and of course, healthy expansion when we're talking about growth. Now, in my clinic, what we do and how we optimize patients' recovery, number one, is we're going to do a 7-point brain and body gut exam. All right. Everybody that comes into the clinic, patient calls in today, says, I want to come into the clinic. Patient staff's going to let them know we don't take insurance, start at 197. Dr. Barlow is the author of 3 #1 best-selling books. He carries a diplomate and fellowship in functional neurology, and insurance is not going to cover this program. And lo and behold, we still have people come into the clinic. So anyway, that's how we deal with this over the phone. So, and then patient come in, we do a 7-point brain, body, gut exam. We're going to do metabolic care. We're going to go over some of that today and how to address this. And then we're going to do regen care, and we're going to be doing that with AGF, PRP, when we're talking about peripheral neuropathy. And so this is the trifecta of what I've seen with 24 years of practice about how we literally have patients getting results that nobody else has. I actually have a patient here in my first book, came in for neuropathy. We utilized this program right here, and he actually is on the very front cover of my book because of the neuropathy pain and suffering that he was having. He had medical doctors that were friends. You can go and spend your money if you want to. Nobody's going to help you. Completely changed the guy's life, and it just goes on and on and on and on. When you take this trifecta approach right here, you literally change people's lives. And remember, when we're dealing with neuropathy, just like any other neurodegenerative disorder, this is a complex, a multifaceted health problem. Okay, now, so let's go through some phone numbers that we're going to need to get. So I sent Will a text, and he didn't send it back, but I'm hoping this is going to be okay because he's actually one of the guys over the accelerated growth factors for plasma. This is Will Stevens, and Will's number is 510 506 5666. So this is Will with AGFPRP. All right. Now we're going to be talking about these push patches that we do for, remember, this is a multifaceted problem. Okay. These are NAD push patches, and this is going to be Dr. Buzz. I just call him Buzz. And if you call him and say, you know, Dr. Barlow recommended me, I was on one of his webinars, he will give you a tier 3 pricing for this, and it's $300. I sell these for $600. Okay. We talked about mitochondria, and we need these NAD patches to help. One of the ways we can do that is to help with mitochondrial function. But you can look up NAD plus and see all of the health benefits of using that. I use Apex supplements. Okay, you can call Angelica with Apex. They're in San Diego. This is her number. And her extension is 6100. All right, because I'm going to recommend things like, for example, nitric balance. Okay, nitric balance. This is there's a lot of things we do, like a 10-week detox, but I'm trying to keep it as simple as I can and get this thing done in as close to an hour as I can. It's called K62. That's their line number, and it has huperzine and some other things in there that's going to dilate the capillary beds. But we use Apex Energetics. I'm sorry, we also use Cyrex. The person you can call for that, let me see if I can do a little better job with my penmanship. She can set you up with an account, because I ask doctors all the time about metabolic care, and they look at me like I've got 3 heads coming out of my shoulders. Okay, no, I don't do metabolic care. Well, okay, let's talk about this just a second. Now, I know with Cara that she does Apex. This is LabCorp. Patients have to bring their LabCorp results. Usually it's piss poor when we're dealing with most, because people do standard of care until they come into the clinic, and usually their blood work is not all that great. But let's look at this person right here. Okay, their T3 uptake is too low, so they're going to have a thyroid problem. Their C-reactive protein. Now think about this just a second. I can't remember what this person came in with. I got their blood work in yesterday. This person's C-reactive protein is 38. So what this means in English is their inflammation is 38 times higher than what it should be. And please, someone help me here. How do you solve these neurological disorders, these progressive neurodegenerative disorders, when somebody's inflammation is 38 times higher than what it should be? All right. She also has her hemoglobin is too low, her MCH is too low, her MCHC is too low, so she's probably suffering with some type of iron deficiency anemia, which means that she may have some gastrointestinal issues, or she may have some internal bleeding. So we're going to have to look at that. And then we flip to the second page and we go, oh, okay, well, your eosinophils are high. That could explain why your iron is low. And so I'm wondering how, when we looked at oxygen earlier, okay, and this person has anemia, I would like for somebody to explain to me, how do we create neuroplasticity when this person has parasites in their gut, thyroid dysregulation, and they have anemia, and she's vitamin D deficient. And then we look at this, and we also find out that she has an autoimmune thyroid. Her thyroid binding globulin is undergoing an autoimmune attack. Now, I don't have time to go through every one of those phases yet, but what I'm wanting you to understand is, how in the world, if this person came in with neuropathy, if we don't address the metabolic side and we're completely blinded by that, we don't even look at that, how are you going to help this person? And then the last number I'm going to write down, this is Dr. Randy. He's out in California. And we're going to be talking about laser therapy. All right. And these are probably, well, not probably, these are the best for the price lasers that I've seen, because you can actually carry these, patients can take these home. So I've given you a wealth of information right here. Okay. And I hope you wrote these down, because we're going to go through each one of these today. Okay. Now, so I told you that patients have or doctors, I'm sorry. If I were to ask each one of you right now, I want you to draw out the large diameter afferent pathways from the foot to the brain. Okay. And literally, you should be able to do that in not even 20 seconds. All right. So I would ask you, if you're seeing peripheral neuropathy patients, okay, it's how in the world are you helping these people when you can't draw out the neurological pathway? You don't know anything about it. If I said, what nerve supply goes to the foot? And if you don't know that, I'm going, why are you marketing these people? And this is why you're not getting the results that you're looking for, because you don't know jack about neurology. You don't know about metabolic care. That's why I'm hosting this seminar today, to change all of that, to help you, because there's, I think 50% of Americans are at least insulin resistant, and any of this insulin resistant, not even diabetic, type 2, it's going to cause these neurological disorders. So in the foot, so we have, let's just draw out the spinal cord here. Now this is the simple part, because I'm not going to draw out everything in the spinal cord. I'm just going to draw out this center part right here. And so let me redo that. The G is in the center. All right, your feet go through this area right here. Now, so what we have is we have these receptors that we're going to test: Merkel's, Meissner's, Ruffini, and Persini and corpuscles. And these two are going to be touch. This one's going to be drag. And this one's going to be vibration. So I'll ask you again, are you testing any of these? Okay, most of you are, you just don't know how to interpret it. This is going to fire into the spinal cord. This is a peripheral nerve here. All right, it's going to fire into the spinal cord, and it's going to inhibit pain at lamina 2. This is what lamina 2, it inhibits that. That's why that little negative sign's there. This is going to fire up through the gracile fasciculus, and then the brain stem. There's 3 levels of the brain stem, and this one is the medulla. And at the medulla, we're going to hit this cuneate nucleus. It's going to decussate. It means it's going to cross over. It's going to fire to the thalamus, and from the thalamus, it's going to fire into the parietal lobe. And this neurological pathway from your feet to your brain fires at 268 miles an hour. All right, 268. So when we're actually testing this, and I'm doing light touch, and people are like taking, 2 or 3 seconds to figure out what I'm doing, this is a problem. This means this system is failing. All right, so this is the neurological pathway when we're dealing with foot problems. It's going to fire through the cuneate fasciculus. How many of you have even talked to your patients about peripheral neuropathy and erectile dysfunction? And then I'll ask you, how many of you actually know the neurological systems between peripheral neuropathy and erectile dysfunction? Because see, you never know when a patient comes in, are they going to come in and do care because they have peripheral neuropathy? Are they going to come in because they have peripheral neuropathy and erectile dysfunction? Why do they have gut health issues? Why do they have brain health issues? So see, when a patient comes in, the person of the 7-point brain body gut exam is to find out neurologically from head to toe what's wrong with this person. We know what the blinky light syndrome is. We know they have neuropathy. But are you talking about their sexual wellness, gut health, and brain health? And I don't have time today to go through all of that. That's why when we talk about my 7-point brain body gut exam, I have a 4-hour webinar on that you can go to Barlow Brain and Body Institute and get that. So let's talk about, since we're talking about the foot here, all right, best I can draw a foot, okay, here's the knee, here's the ankle, all right, real simple. Real simple. In the foot, this is the small toe over here. This is the great toe here, right here. This is the great toe. So everything in the foot from the ankle down is controlled by, on the dorsal aspect of the foot, is controlled by L5, except for the small toe. All right. And how simple is that? Small has an S in it. It's going to be S1 nerve root, and it's going to be the sural nerve. Okay. And here in this center part here, this is still L5 between the webbing of your big toe and the second toe, but this is the deep peroneal nerve. And then the L5, this is called the superficial peroneal nerve. All right, on the outside of the leg, superficial peroneal nerve. And it comes across the lateral side of the foot to the dorsal aspect of the foot, and it controls all the toes except for your small toe. All right. So see, when you understand the neurology, then you can look at a person with confidence and go, here's what we know neurologically. Okay. Number one, did we do a pulse ox? Okay, we looked at their blood sugar, it's dysregulated. That's got to be worked on. We looked at their oxygen level. That's got to be addressed. We do a pulse ox on their finger and their second toe to see tissue perfusion, how well we're getting oxygen to the distal extremities. So now we've got decreased oxygen. We've got, we're testing their temperature, which we're going to go through the blood flow in just a minute. And then we've got decreased oxygen, decreased blood flow. We've got an L5 nerve damage, okay, because of the degeneration in your back. And see, all of these have to be addressed to help optimize this person's recovery. So and the dorsal aspect of your foot, L5 controls all of this except for your small toe, which is your S1 sural. Now, when we're talking about blood flow, why do we need to know blood flow? Well, again, when we do the accelerated growth factors, which I have a handout for this, and if you want this information, you can contact me, okay? And we hand this out to patients so they know what they're what to be expected when our medical doctor does the injection, and and the areas that we're going to be injecting. And then we talk about neuroplasticity, neurogenesis, and we talk about also increasing blood flow. All right, so what are the blood flows that go into the foot? There's actually 3 of them. One is kind of ignored a lot because it actually goes to the posterior aspect of your leg, kind of on the lateral side, and it goes to the calcaneus. Okay, that's called the peroneal artery. All right, so it's kind of neglected. It's kind of like the uncle that comes over for Thanksgiving. You're kind of like, I kind of wish you didn't come over here. But I know we're the only one that had that uncle. But the point is, there's just one little artery that people kind of forget. So when we're looking at that, heel pain, on the lateral side, we might need to know about that artery. All right. Now, so the main 2 arteries are going to be you're going to have the femoral artery, and then which is going to be in the front of your leg, front of your thigh. And then as it moves into the popliteal artery, it actually goes to the back or posterior aspect of your knee. And just below the popliteus, which is a muscle that unlocks your knee, major contributing factor to knee pain and degeneration, but that's for another webinar. Just inferior to that, you're going to have a branch, and that branch is going to come off from the posterior aspect, and it's going to go between the tibia and the fibula, okay? And that branch is going to transverse the interosseous membrane and go into the anterior part of your leg. And guess what it's called? You're not going to believe this. Anterior tibial artery. All right. And then the anterior tibial artery is going to go down into the foot. And once it crosses the ankle, it's called the dorsal pedal artery. All right. And then now that's what controls the blood flow into the dorsal aspect of your foot. I'm giving you the simplified 1-hour version here, okay? Now, so we've got the anterior tibial artery that once it gets into the ankle is the dorsal pedis artery. Now, we also have in the posterior aspect of our leg, hold on to your seat, this is called the posterior tibial artery. Now, when we look at if you look at what is called the muscles and the tendons called Tom, Dick, and Harry that come off the tibial nerve. Now, the muscles are not actually Tom, Dick, and Harry. It's the posterior tibialis, the flexor digitorum, flexor hallucis longus, and flexor digitorum longus. That's your Tom, Dick, and Harry. Those run together into a tendon, and the posterior aspect and posterior and inferior aspect of your medial malleolus. Now, why is that important? Because the tibial artery runs right, posterior tibial artery runs right in with them. Okay, and then it's going to branch into the medial artery and the lateral artery, and that's your blood flow to the bottom and the top of your foot. So I'll ask a question. When you're doing these tests with this simple little scan right here, very inexpensive. I have another one that's like $600. Just going with the simple stuff today. Do you test the dorsal and the plantar aspect of the foot? You should, because there's 2 different blood supplies going there. Because I've had some people, they'll say, well, I've got numbness and tingling on the bottom of my foot, but the top of my foot feels fine. Or I've got it in my whole foot. And just remember, when we have decreased blood flow, that hypoxia, that hypoxic state, that in and of itself can cause numbness, tingling, and pins and needles. Okay. Now, the next thing that we want to talk, we talked about the neurology in the leg. We talked about the blood flow to the leg. Now, let's talk about managing the patient's expectations. All right. Now, you remember the old OPQRST. All right. So for the startup. So when did this thing start? Let's just say 10 years ago. What does it feel like? Okay, it feels like it's numbness, tingling, and pins and needles. It feels like it's burning and painful. That's our small diameter afferent pathways. So you have large diameter afferent pathways, and you have large diameter and small diameter afferent pathways. Now, the reason this is important is because these small diameter afferent pathways are C fibers, dull, achy, pain. And then we have what are called the small diameter afferents are A delta, and the A deltas actually have myelin. So, do you have this small diameter neuropathy or do you have large diameter neuropathy? Large diameter neuropathy is going to lead to numbness, tingling, and the needles. And when you have small diameter neuropathy, this can cause pain. Now, most of you, guaranteed, take it to the bank, 9 out of 10 of you that actually see neuropathy patients don't even tell patients this when they start care. You're probably going to get worse before you get better. 50% of patients do. Okay, because here's what happens: is when your neurological system starts to regenerate, called neuroplasticity, then the analogy I use is a construction worker. If you're building a house and your contractor is building a really big house, large diameter afferents, and they're building a really small house and they start at the same time, which one of these houses will probably get built first? And the patient is going to say the smaller house. And I go, yes, the reason I'm telling you this, because see, people learn by using analogies. The reason I'm telling you this is because once we start this regeneration with doing medical doctor doing the injections and the in-office therapy, you may start to feel some pain at the beginning. The reason for that is when you have this neurological system that's failed, you don't feel anything. And then when the nerves start to regenerate, typically the first nerves that regenerate are the smaller nerves first. Okay, because here's what will happen if you don't understand the neurology. You're like, oh crap, this thing's not working because the patient didn't have any symptoms except numbness and tingling a month ago, and now they're feeling pain. Guess what? Because you don't know neurology, you can't explain it because you're basing everything on their symptoms. Their body, their nervous system is actually regenerating, and the small diameter afferents are going to regenerate first. Saves you a ton of money, but you got to manage the patient's expectation. You got to tell them that before they come in and go, Doc, my feet are killing me. Okay, you can't tell them then. It's like, oh yeah, that's just part of the healing process. Then you sound like a snake oil salesman and all of that. And just tell them up front what's going to happen. Again, doctors, with me coaching them throughout the years, I have discovered that they're piss poor at managing patients' expectations. They're too busy trying to make the close, too busy trying to collect the money. And I'm all about that too. But also, we want to manage the patient's expectations so we can them through the journey together. All right. So, how long have you had it? What does it feel like? Quality of care? Does it radiate? All right. Now, why is this important? This is real simple. This is, again, radicular pain versus metabolic pain. Take your pointy finger and tell me where the problem starts and where it moves to. If they say it's in my feet and it's moving up toward my body, that's more metabolic. All right. If they point to their back and they go down the leg, that's more radicular type pain. So and see, now we're going to have to use regenerative medicine to possibly look at their back and their feet. Okay. So again, if it's in the spine going down, that's radicular pain. They're going to say it starts here and goes down. If it's more metabolic, it's going to be in my feet and it's going to move up. Okay. Let's see, radiating. What have you been able to do to make this better? Well, here's the clue. The reason they're in your clinic is because nothing has helped them. Medicine, conventional medicine, swears up and down nothing can be done about this. Conventional medicine also knows very little about neuroplasticity. All right. And so the point is, we have to ask them, tell me the one thing that's improved this function. And their answer is going to be nothing. All right. That's part of the magic. Okay. That's that 80-20 rule when it comes to sales. 80% of sales is psychological, and 20% is actually intellectual, if you will. So what we want to do is we want to get them to understand that 80, or we're going to convey to them in that 80%, which is psychological, nothing has helped. They said nothing has helped. We're not putting words in their mouth. They said nothing helped. All right. And then I'm going to ask them, how many doctors have they been to? 4, 5, or 6. Let me get this straight, Mr. Smith. You've been to 4, 5, or 6 doctors. Nothing has helped. Okay. On a scale of 1 to 10, 10 is you're in a wheelchair. You're already in a walker. Okay. Or whatever they're in. But the point is, you're on a scale of 1 to 10. 10 is you're in a wheelchair. 1 is you have no problem. Give me the number that you're at today. And I'm going to say, if you continue down this same road, where do you see yourself 9 months from now? They're going to tell you. It's going to get worse. What does that mean? What does that mean to you and your spouse? What does that mean to you and your children? How's that going to negatively impact your life when it goes from, a 7 to a 9? You just sit there and listen and write it down. All right. And then what number do we need to get this to for you to be happy with the result? And all I have to say is, you've had this problem for 10 years. Let me make sure I got this right. You've got had this problem for 10 years. You've been to anywhere from 4, 5, or 6 doctors, correct? Nothing has helped. You're currently at a 7. All right. You said in 9 months, you're probably going to be at a 9. And you told me that you're not going to be able to go on vacation. You're not going to be able to go to your grandkids' ball games. And that's very upsetting to you. And you said you would like to get to a 2 or a 3. That's where you would like for us to get you to. Okay. So now something to work with. All right. And then we go in and do the neurological exam. Okay. And then we find out the devastating effects of how bad this problem is. And we're going to talk about the exam at the end of the talk today. But see, this is OPQRST. This is not about just checking a box. This is gathering information about, where is this person? Okay, because if you don't do the startup correctly, and then somebody says, well, Doc, I need to go think about it. I know I'm the only one that's ever heard this, or don't have the money, or then see, there's easy ways to solve this if you have something in the toolbox to carry on a conversation with the patient. Okay, all of these problems that you're confronting here can be solved, but they can't be solved the way that you've been doing it in the past, more than likely. All right. And that's why you're here. I'm telling you, like I tell patients, if you knew how to fix you wouldn't be in this clinic. Here, looking for advice from someone that's an expert in this field. Care if you're in real estate. I don't care if you're Grant Cardone. I don't care who it is. You've got to be able to answer those questions. I know some in there and go, man, I hope nobody asks me about money. Well, guess what? They're going to. I hope nobody gets upset because when I did this exam, it's going to take 12 months. Well, that's not your problem. Your job as the doctor is to do your moral and ethical obligation, which is to do and with them low, and then let the patient decide the direction they want to go with their life. I don't sit here and try to judge people. I just say, here's your problem. This is what can be done about it. And then if they say something about I need to think about it, and we're going to get to this at the end, here's one of the things you would say. Now, let me get this straight. Make sure I'm understanding you correctly. You said when you came in that you've had it for 10 years, numbness and tingling, getting worse. You're at this point. You're going to be at this point in 9 months. You want to get to a 3 or 4, and then, or whatever the number is. And then, Mr. Smith, tell me, what is the benefit of you waiting? What is the benefit of you doing nothing? Because you've already told me if you do nothing, this is what's going to happen. But see, you got to have the kahunas. I have this right here at my table. Okay. So If you need a pair when you come to Tupelo, you can borrow mine. But the point is, doctors don't have the kahuna that it takes to talk to patients the way they need to be talked to. And it's not about disrespecting people. It's about getting them to understand it's like nobody's helping you. This is the potential solution you've been looking for, because in my clinic, if I couldn't help people, I don't accept them for care. I literally send them out the door. I don't just send them out the door and go, hey, it's your responsibility. I actually refer them to the appropriate healthcare provider. So hopefully this has been a little bit beneficial right here. But hopefully I won't screw this part right here up. And let's see if we can make this thing work. All right. I may carry a diplomate and a fellowship in neurology, but as most people that know me can tell you, it's like my electronic computer skills are not the best in the world. All right. So mastering peripheral neuropathy, neuropathy management. I probably should have put this up at the beginning. This is a disclaimer. There's the disclaimer. Merry Christmas, Happy New Year, and Thanksgiving. So there you are. So there's my disclaimer. I'm the author of 3 #1 best-selling books. If you want to contact me about anything that we're going to go over today, this is my contact information. There's my phone number. Call the clinic, or call the, not my clinic, don't call the clinic. My staff's got enough to do. You can call the Barlow Brain and Body Institute, and I can help you with anything that I can, and I'll even go if you've attended it. Pay a dime for it with a metabolic. I'll do that. I won't even charge you for it. Okay. I've written 3 #1 best-selling books. I'm in private practice. I've been coaching doctors since 2008. But see, I know the questions to ask doctors because I know what they're not doing, because I've been coaching doctors since 2008 from all over the world. So I know how to communicate with patients because I know what the healthcare profession is not doing for them, or profession is not doing for them. I know nobody is helping them. I know they're in here because they haven't gotten any results. The patient has to say that question and gather information. That's part of the patient management. I have a advertisement that I do. I have a TV commercial. We weren't able to get this on here today, but if you will go to the email that I just had up, right here, Barlow, the info at barlowbrainandbody.com. I'll give you the TV commercials that we run. Currently, I have 8 different TV commercials, and I was funny because I was out to lunch yesterday, and one of the chiropractors in town was like, "Oh yeah, we just started a TV commercial." I'm like, well, okay. I got like 45 TV commercials. I've got 29 with patient testimonials from everything from dementia to movement disorders and seizures to peripheral neuropathy, all the way through whiteboard ads, and I'll send you the whiteboard ads. I have 8 of those. And so if I've got 45 holes in the water and this doctor has 1, guess who's probably going to catch more fish? And see, again, it just had to do with piss poor marketing. All right. And I'm trying to be nice here, but to solve problems, we gotta call it what it is. All right. And no, we can't, tiptoe around this. I'm in active practice in Tupelo, Mississippi. All right. We got to market to the right audience. We got to have an effective marketing campaign tailor-made to neuropathy patients. We have this. And again, I didn't have time to put this on the webinar today, but if you go to my website or to my email address, I'll send those to you. All right. Part 2, conducting a comprehensive exam. All right. The key to a thorough neurological exam, techniques to improve patient comprehension and consent. What is the research? Patients don't care about this. I'm giving you this as a doctor. Now, if you go to barlowbrainandbody.com for $247, you can order my 7-point brain body gut exam. It's 4 hours. All right. So 4 hour, and we go into detail on this. So what we're going to need to do, let me get through this so it'll make more sense. Setting patients' expectations. Now, if you don't want to copy this off, then I'll send one to you. Down here at the bottom, it says, validate of the Toronto Clinical Scoring System for diabetic neuropathy and diabetic care. But the point is, this is peripheral neuropathy damage. So I want you to look at acute care and see it takes 7 to 9 months. And the problem is, this is where the doctor's patients is communicating with their patient's expectations, because you may be seeing patients for, I don't know, 3 months, 6 months. I think I have 2 patients under care right now, and they're not neuropathy patients. That's a 6-month program. All of my neuropathy patients start at 9 months. Okay, but again, my program for that starts at $15,961. Okay, so you're going to have to up your game. You're going to have greater margins. That's what it's all about. You can't dive to the bottom. Okay, it's like you're not Walmart. You don't have the best prices. I'm not trying to have the best prices. It's not about me having the best prices. I didn't get to where I am because I've got the lowest prices. I got to where I am because of having high margins and being able to market to get more people to buy all this equipment that I have in my clinic. Okay, to be able to advertise to get more patients. Okay, let's look at this. Moderate nerve degeneration. Moderate is 9 to 12 months. And then severe, this percentage range up here, 18 to 19, 12 to 18 months. I literally have people in my clinic, not many, but I do have them in here that's actually 24 months worth of care. All right. And this is in the tens of thousands of dollars that these people pay me to help them get their life back. All right. So let's go through. There's your chart. And then here, this is what's important. Here's the research on here somewhere about how fast peripheral nerves regenerate. And most doctors don't even know this. These nerves regenerate about 1 inch a month. Okay, and it's according to how much nerve damage they have and all of that stuff too. But just look at where your spine is and where your foot is. Okay, for most people, that's probably going to be 2 feet, 4 feet, 3 feet maybe. Unless you're a midget, it might be, I don't know, 18 inches. I don't know. I don't have any midgets coming in here. But my point is, that is a long nerve for most people. And if it's going to regenerate 1 inch a month, okay, why in the world are you putting somebody on a 3-month program? All right. So that's the point that I want you to understand. Here's the research behind that. But see, doctors don't know this crap, and they don't know how to manage the patient's expectation. Here's the research here as well. Okay, this part you need to copy down. If you want a nicer, prettier picture on this, just go to info@Barlow Brain and Body, and I'll send it to you. All right, so let's going to keep this real simple right here. All right, how hard is it for a patient to fill out these first 10? Please forgive me, it's on a Tuesday and I'm at work at the office, so the phone's going to be ringing. So the first 10 right here, we're going to keep this real simple. And we're going to use the number 4 on every one of these, just to keep it simple. All right, so 4. All right, it states up here that 0 indicates no pain, 10 indicates the most intense pain imaginable. So I don't have to sit here and calculate everything. We're just going to say 4 across the board. How intense is your pain? 4 out of 10. How sharp is your pain? 4 out of 10. How hot is the pain? 4. How dull is it? 4, blah, blah, blah. So how simple is this? There's 10 freaking questions. 4 times 10 is what? 40. It's 40 out of 100. Now let's go back and look at this. This is the patient saying this, not me. And look at where 40% is right here. This is at the outer end of moderate. And that puts this person right there just from their symptomatology. We haven't even done an exam on them yet at a 9 to 12 month program. That's just at a 4. Okay, just at a 4 out of 10. So 40% loss of function. All right, so now what we need to do is we are going to take this information. We're going to have this sheet with the patient. We have this information that's filled out. Okay, we're going to present that to them. We have an objective finding. They said that they're 40% loss of function. Research shows 40% loss of function is 9 to 12 months. And then we're going to do a head-to-toe neurological exam and find out how much loss of function they actually have. And we're going to do that in just a second. And then we're going to put them on a program which has to do with accelerated growth factors. And I'm going to show you the science behind that as to how these patients are going to get results. Now, our medical doctor, this is the lateral side of the leg at L5 dermatome. So if you look at that blue dot, that leg that's in the front, this is where the injection sites are going to be. L5. All right. And then here at L4 on the medial side of the leg, L4, okay. And then the inferior aspect about 2 inches above the medial malleolus, we're going to be doing another injection site. So we're going to be doing, our medical doctor is going to be doing 3 sites over a 4-injection period, typically every other week. Now, this is important. When you look at a patient and you look at them metabolically, neurologically, and we do regenerative medicine, typically, I use the word typically, I said typically, right? Typically, the patient, no, I don't have a speech impediment where I keep repeating myself, but you need to get this. Typically, by the 3rd injections, patients are seeing results. But again, we're not just doing one thing, okay? We're doing multifaceted healthcare to a multifaceted neurodegenerative disorder. Okay, so stop thinking that we're going to do one thing on this neurodegenerative disorder that you're going to make like this, you're going to sprinkle magic dust on these people. We have to put this whole picture together. All right, this is why I wrote the book, The Code Breaker, because there's not just one thing. It can be 7 different things, and each one of those 7 have multiple factors in there. I already said this. 7-point brain, body, gut exam. You can go on there, $247. This is my next level 1 seminar, and we're going to be hitting peripheral neuropathy like a maniac. All right. So this is what I'm getting, and we're going to get into plasma, accelerated growth factors here in just a second. But at my next level 1 seminar, which I have on the screen here, it's going to be 16 hours. It's going to be recorded. Hopefully the internet in Mississippi will be a little bit faster than it is right now. Okay, but if it's not, we're still going to be recording it online live, and we're going to be recording it just like I'm doing here so we can send you the video. Well, this is what I'm going to do. All right, this is going to be a 16-hour peripheral neuropathy from marketing to startup, how to do the exam and everything. Okay, it's $1,500. If you can, since you're on this free webinar because of Plasma Solutions, I'm going to take $250 off the seminar. And if you buy the 7-point brain, body, gut exam, I'm going to take another $250 off. So you can come in, get a head-to-toe metabolic injection type of seminar for 16 hours. You can get that for $1,000. And I'm going to teach you how to do $15,961 care plans and up. All right. I don't know why anybody would want to go to that. To show you how to get better results, faster results, and patients not complain about their health care. Imagine that. All right. Now we're going to do a Q&A at the end. All right. So let's go back through this part here. All right. The patient came in and said on their paperwork, they filled that peripheral neuropathy program out that they're for. Now we're going to tell them, it's going to take, according to what you told me and this research here, somewhere between 9 and 12 months. Okay, you're not pulling a rabbit out of the hat. This is what the research states. All right. Now we're going to do a neurological exam and get a little bit closer to see what's going on right here. So what we're going to do, number one, is we're going to look at their oxygen. We're going to look at their tissue perfusion. We're going to look at their temperature. We're going to take a temperature of their face, surface temperature. All right, mine's 90.3. And then we're going to have their shoes off and their socks off, and we're going to look at the top and the bottom of their foot. I've got a little bit of feedback right there. Sorry about that. Top and the bottom of the foot. Why? Because the top of the foot, you've got the anterior tibial artery. The bottom of the foot, you got the posterior tibial artery. Now, hopefully, when they come in, like I've got tile in my office, but where I do an exam is actually carpet. All right. And so, but you can touch people's toes and go, wow, that's cold. Your hands are cold, but we need a number. Because see, again, everybody's going to base it on their symptoms. But what if this person had the temperature 12 and their feet from their face, and a month later, all right, it goes from a 12 down to an 8-degree difference. All right. Do you think they're actually going to feel that 4-degree difference? Probably not. But see, we've got some indicators here by the numbers that they're actually improving. What if their oxygen level, they came in and their toes was like 90, I don't know, 2. All right. And then a month later, it's at 94. Okay. Now we've got the substrate. We've got blood flow. We've got oxygen. We've got the substrate that's there to help the tissues repair. The way I explain to patients is, have you ever built a house? All right. Well, be thankful if you hadn't, because I built one and it's a pain in the backside. But the point is, I use that analogy of You can have all the brick at the site. You can have all the lumber at the site. You can have all of the landscaping at the site, but you still got to have somebody to put all of the pieces together. So what we're doing here with the accelerated growth factors, what we're doing with the brick that's on the outside, the in-office, we're getting all the construction crews together to actually start laying the foundation for neuroplasticity and to allow these nerves to regenerate. And now what we're doing, see, in a month, we've got better blood flow, we got better oxygen. We're going to do a temperature. And if you want my neurological exam form, go to info@Barlow Brain and Body. I'll just email it to you. All right. So Steve, one of the things that we're going to do is we're going to put the tuning fork on their sternum. This is the baseline on their sternum. It's a Meltex 128 hertz tuning fork. This is the 10. We're going to put it on their thumbs. All you have to say is it more, same, or less. All right. We're going to stay with the stick with the feet for this seminar today. I'm already at an hour. All right. We ain't even gone over plasma solutions yet. But we got to get. This is why I'm telling people. This is why you're getting irritated, because you're like, we're not getting any results. Well, because you're not doing your job as a doctor. You're not managing the patient's expectations. You don't talk about how long it's going to take. You're putting them on a 3-month program, a 4-month, 5 months, 6 months, and there's no research probably to back that up. Okay, because again, even if they're at acute care, which means they're at about an 18% loss, they're going to need 7 to 9 months of care. They're at a 2 out of 10. 2 out of 10. All right. How many people come into your clinic that's a 2? Nobody. Okay, and they're going to pay for care. They're further down this line right here. Sternum is a 10. Test the thumbs. Okay, bilateral. We're not ignore that today. We're going to test the great toe. Now the great toe, let's just say I feel that at a 6. Just keeping the number simple. This is textbook. Nobody's going to go exactly this direction, but we come up here and go, wow, if I feel that at a 6, that means you got a 40% deficit. Wow. Amazing how that is. Your subjective statements when you filled out the paperwork stated that you had 40% loss of damage. The Toronto study has been shown that when you have 40% loss of damage, you're going to need 9 to 12 months worth of care. When I did the tuning fork, you were at a 6, which means you have a 40% loss of damage. You're going to be 9 to 12 months worth of care, but we're not done yet. Now, what we're going to do when we actually look at the patient's foot, we're going to go to the foot here for just a second. Let me see if I can hopefully not screw this up. All right. We're going to share whiteboard. All right. Let's go back to the foot again. All right. This is the great toe right here. All right. All right. Again, great toe right here. All right. Now, there's no science to back this up. I've just, over the years of actually looking at this, patients really get this. What I'm going to do, Mr. Patient, is I'm going to touch your fingers. I'm going to touch your fingers, and I'm going to demonstrate it on your fingers. So this is actually the patient's fingers, not mine. All right. So how many fingers are between the fingers I'm touching? That would be 1. Okay. You have to make sure they understand 1, because what they actually hear is, how many fingers am I touching? And that's not the question. It's how many fingers are between the fingers I'm touching. How many fingers are between the fingers I'm touching? None. How many fingers are between the fingers I'm touching? 2. Perfect. All right. Now we're going to close our eyes, and what I'm going to do is I'm going to touch your toes, and I want you to tell me how many toes are between the toes I'm touching. Okay. We're going to do 3 tests. If you miss one of those, okay, that's going to require 3 months worth of care. Okay, so here's what we're going to do. We're going to come in here and we're going to do a light touch. I was hoping it would actually do this. We're going to, all right. So we're going to take the patient and we're going to do a light touch like this on their finger, on their toes. Sorry, because this is a peripheral neuropathy, lower extremity. So we're going to go touch, touch, touch. How many toes are between the toes I'm touching? All right. Remember, we got to put all of this together. That neurological pathway is firing in at 268 miles an hour. So as soon as I touch their toes, they should be able to tell me exactly what I'm doing. So if they're slow and they get it right, which usually if they're slow, they're going to miss it. Okay. That's automatically 3 months worth of care. This is why their spouse has to come in with them. Okay. Yesterday, we had a lady come in. Literally, this woman came all the way from South Dakota, drove to Tupelo, Mississippi for me to see her. All right. And so some of y'all can't get people to come from across the street. I got people from 20 different states coming in here. All right. So I'm Andy Barlow. I'm your friend. But we gotta expand. All right, not contract. All right. So and I'm touching her toe, and her son actually gets up, her husband's son, and he's like, "You mean you can't feel that?" And she goes, "I don't know what he's doing." All right. And so that would be 3 months of at-home therapy or in-office therapy. All right. Now we're going to hold the toes down. So if I hold the toes down, and if you one of those three, that's 6 months of care. So like this, hold the toes down. How many toes are between the toes I'm touching? I know I'm doing fingers, but in this illustration, we're doing it. And day 2, I tell the patient, look down here, and they're like, oh my gosh, I couldn't feel that. I'm like, I know, because you've got neuropathy. You've got a complex neurological neuro disorder. See, that sounds even worse than it's just what it is. I mean, I don't over exaggerate, but it's a neurodegenerative disorder. All right. All right. So they miss 1 out of 3 of those. I'm going to do it bilateral. That's 6 months worth of care. Then I'm going to tell the patient, Mr. Patient, look down here. This is toe number 1. This is toe number 2, 3, 4, 5. 1, 2, 3, 4, 5. Actually, this guy's got 6 toes. I didn't realize that until just now. So, nevertheless, most people in Mississippi have 5 toes on each foot. So anyway, I know there's all kind of Mississippi jokes we can make about that, but nevertheless, we're going to say 1, 2, 3, 4, 5. I'm going to touch one of your toes, and I'm going to take one toe on the left foot, like toe number 4, and I'm going to touch toe number 3 on the patient's right foot. Remember, the patient's facing me. All right. I'm going to say, which toe am I touching? If they miss that, that's a 9-month program. 9 months. Lo and behold, if we don't see that this 40% loss of deficit is what? 9 to 12 months. Now we're going to see about if they're going to need more care. I'm going to draw a number on your foot. Close your eyes. I'm going to draw a number on your foot. All right, this is called graphesthesia. Remember that Ruffini's that we talked about? Go back when I talked about Merkel's, Meissner's, Ruffini, and Persinian corpuscles. We're testing Merkel's and Meissner's by light touch. We're testing Persinian by vibration. Now we're going to do the drag. This is a higher order brain function here. Okay, no Mississippi jokes. Okay, higher order brain function here, because now what we're doing is we're looking at the parietal lobe association cortex. When we do the light touch and vibration, we're looking at the somatosensory cortex, area 3, 1, and 2. Okay, no, I know how to 1, 2, and 3 in numerical order, but the way it's in the parietal lobe is 3, 1, and 2. That's your primary somatosensory cortex. So when we're doing these individual testing of the toes, how many toes are between the toes I'm touching, we're testing area 3, 1, and 2. Here we're looking at the association cortex in the brain. Can you associate this and tell me what that number is? It's always in the frame, the reference of them. Their frame of reference is what I'm trying to say. Because a healthy functioning person, you can draw a number sideways, upside down. I could draw a 3. If this is a person's foot, I could draw a 3 like this, and they would say that's a 3. Okay. But we're not trying to confuse the patient. If they miss the graphesthesia in the foot, that's a 12-month program. What happens? I said with metabolic care, it goes from the feet and it goes up. We're going to go up to the knees. We're all the way up to the knees. Patient, keep your eyes closed. If they miss it at the knees, that's 18 months. If they miss it in their hands, that's 24 months. Okay, thank goodness I don't have a lot of people that's on the 24-month program. But see, now we actually have an exam where we can explain, hey, you said that you're 40% loss of deficit right here. All right. The Toronto scale system said that if you have 40% loss of damage, then that's a 9 to 12-month program. We're going to do a more extensive exam right here. We're going to do vibration. That feels like a 6. Wow, that's 40%. Okay, now we're going to do the digit span test. How many toes are between the toes? So everything is coming in here. Like, for example, one patient that's at 40% loss, they may actually need 9 months, and then we draw the 7 on another patient, and they need 12 months. Okay, that's a whole different program. That's 18,961. So, and again, wherever you're from, patients in Mississippi pay that. Okay, because I hear You know, people say, oh, they won't do that in my town. I don't know if you've looked up or not, but in Mississippi, we're the fattest, the dumbest, and the poorest state in the union. And for some reason, people find the money to do things that are of value to them. And that's what you have to get out of the patient. Is this of value to you? All right, we're going to wrap that up at the end. All right, now let's get into, all right, this next part here. Let's see here. Screen share. Got a new screen here. I may have to do this. So hopefully this right here will work out. And when I got the PowerPoints, it wasn't PowerPoints. It was actually, let's see, where is this on here? It wasn't PowerPoints. It was actually a PDF. Let's see if I can get this pulled up here. Give me just a second, you guys. May have to, let's see what I got here. Give me just a second. I figured that the doing on the PDF was going to mess me up a little bit here. All right, let's see if I can find this thing. All right, what I'll do is I'm just going to read this to you. I have it on my, and don't worry, what we have is you will get the actual PowerPoints to this. If you don't already have it, you can go to barlowbrainandbody.com and then we'll have that. And I do apologize. I figured there was going to be a problem with me sharing a screen and having this PDF form up here because it was supposed to have been sent in PowerPoint form and it's not. So I'm having a difficult time segueing from sharing the screen. All right, we'll try this one more time and see if I can make this happen. Let's try that right there. See if we can do something here. Guys, just bear with me for just a second here. And if not, we will I don't seem like I can get that to pull up. Okay, so let's go through this. You'll get a PowerPoint on this, and I mean an email. So accelerated growth factors is plasma solutions. That's the actual. I gave you the information from Will. Now here's what you need to do. And I apologize about going over. I knew I couldn't get this done in an hour. Will and James, which is the developer of accelerated growth factor, they're the ones that sent this PDF. This is the company that I use. You can use it for joint pain. You can use it for peripheral neuropathy. We specifically use them for peripheral neuropathy pain in the lower extremities. Now, when I was set up with them years ago, I think I've been using them since 2017. They can clarify. They know the exact date that I started with them. I don't stay with people that doesn't work. And so this is why I've used this company for 7 years now, is because we've gotten great results with them. All right. Back when I signed up with them, they had a 45-minute video, not a video, but a conference that they sat down with you and your medical director. And I'm assuming that they still have that. So, but we need to get that set up. So it's a 45-minute. They only do 2 clinics at one time. So because they want to make sure they get all the questions and answers that you have. So please call Will. I gave you their number so they can get a time set up with you so he can go into more detail with this. All I can tell you is, again, I consult doctors all over the United States. I'm not getting paid to do this seminar today. Okay, Plasma Solutions do not pay me. They don't pay me a referral fee. I'm making no money from them doing this. All I'm trying to do is say there's no reason for you to have this pain and suffering for you as a doctor when you're seeing peripheral neuropathy patients. The reason you're not getting the results is, number one, is because you're not managing the patient's expectations. You don't know how to set up an appropriate care plan. and you're not looking at it from a multifaceted approach. You're probably doing all three of those if you were to be honest with yourself. So again, with plasma, platelet growth factors and peripheral blood-borne stem cells, the body's response to injury. So they respond to injury through the platelets, specifically designed for healing and regeneration. They are injury healers. That's important, and they are natural in the blood and born stem cells, proper concentration, and they lower pain levels. Okay, now back in the day, back years ago, we did mesenchymal stem cells. Okay, and we stopped doing that because we started doing platelet therapy. And we live in the South, the Bible Belt, and I don't care how many times you tell people, they still think that it comes from aborted fetal tissue, or some of them do. I'm like, no, it doesn't. So people like using their own products. If there's a way that you can heal your body with platelets, people like that. Okay, and maybe it's just my mindset, but people sure do like, taking their own blood, spinning it down, and injecting that back into their body, or injecting their platelets back into their body. Okay, it's super concentrated, and that is enhanced and the activator and activated. Let's see, super concentration growth factors. That's important. It has growth factors, which recruits native adult stem cells. These native stem cells are activated by the efficient. The cells are active and efficient at any age. So these platelets are activated at any age. So somebody comes in, I literally have one lady that's 94 years old that's in my clinic. I got another guy that's 90 years old that's in my clinic. On the PDF, it says it's non-painful treatment in Mississippi. I can't say anything is a non-painful treatment, but that's what accelerated growth factors had stated. Compliant patients have accelerated rejuvenation of nerve tissue. Okay. Tendons, ligaments, muscles, stem cells, growth factors, and platelets make this happen. Our recommended protocols provide a clear path for success, and I can vouch for that. Okay, and again, this is one of the three things that we do to optimize the patient recovery with peripheral neuropathy. All right, our technical and clinical support have played a key role in making practice and treatment successful. That's why I'm here today, to help you get better results with these with peripheral neuropathy. Now, again, the way this is set up is we do peripheral neuropathy injections, like we talked about, L4, L5 dermatome every other week for 4 weeks. And then if you have a joint problem, you can use accelerated growth factors for joints as well. It's a 3-visit, or every other week for 3 weeks is the way we do in our clinic if you have any joint health issues. It is common for patients suffering with diabetes to have neuropathy. Can also caused by long-term use of statins. So understand that statin drugs, around the large diameter afferents, you have myelin. Okay, and myelin is just, if you have low cholesterol, you're going to have a problem producing myelin. So I don't care what anybody, if you Google and look up cholesterol, neurologically, it is devastating to your body if your cholesterol is below 150. And I see these idiotic ass medical doctors trying to drive. I see people coming in with 117 in their cholesterol. I don't even know a way physiologically you can do that. These people have to be on statins, and they're wondering why they have no sex drive, they have no drive at all, and they have numbness and tingling in their hands and feet. It's because you're driving your cholesterol is way too low. Remember, all of your hormones derived from cholesterol. So neuropathy can come from long-term effects of chemotherapy. Many patients are on painkillers. I call them 2-baggers. In my second book, you got a bag of drugs in this hand, a bag of drugs in this hand, and I ain't better today than they were 10 years ago. Leg cramping, okay, is common. So let me explain this, okay. Here's a peripheral nerve, all right. Inside of the nerve, there's 9 nerve fibers, all right. So 2 of these nerve fibers, okay, control our autonomic nervous system. All right, the diameter that called the blood flow, the diameter of your blood vessels. 2 of these nerves produce pain. So see, if I tell patients all the time, if I came in here and I just treated your pain, I'd be treating about 20% of your health problem. Okay, So 2 out of these 9 nerves just produce pain. One of these nerves have to do with balance and light touch. 4 of these have to do with motor function. So see here, when you have peripheral neuropathy, you could have damage in any of those 9. Any of those 9. Okay. So one of the ways you can tell if they've got some type of motor, when's the last time you picked one of these things up? I know some of you may not even know what this is. Sarcasm. It's called a reflex hammer. Okay. Are you hitting the patellar reflex? Are you hitting the Achilles reflex? I didn't have the study up here, but a study, and I wish I'd saved it and put it on here, but there's a study that shows that if you lose your Achilles reflex, that your nervous system, even though you may be 60 years old, chronologically, neurologically, you're 80 years old. Okay. Usually that will wake people up when you tell them that. But see, here in neuropathy, it has to do with leg cramp. Why? Because peripheral neuropathy doesn't just produce pain in large diameter afferents. There's motor pathways in there as well. Many people have sleeping problems. Many patients have low sensitivity on the soles of their feet. That's part of the neuropathy program. You need to ask them, show me, take your pointy finger, show me where the problem is. The top of the foot, bottom of the foot. Where does it start? Where does it end? All right. There are many treatments, but most do not find the effector, or they only get to a temporary relief. All right, now platelets. Okay, accelerated growth factors. Okay, this is what they are. Platelets, all right, derived growth factors. They're transforming growth factors. And these transforming growth factors, or TGF, actually activates mesenchymal stem cells. You can look all of this up. I'm just giving you the big picture here. Platelet factor interleukin, platelet-derived angiogenesis factor. Okay, what is angiogenesis? It creates new blood vessels. See, patients need to know that. We have to create new blood vessels in order for your body to heal. When I said Dr. Randy earlier, this is part of the home therapy that we use. This is the laser therapy that we use for patients at home. Okay, if you call Dr. Randy up, okay, these lasers are, I think, $3,000 a piece. If you say, hey, I was at a webinar with Dr. Barlow, and what if he will let you buy 5 of these for $5,000. I sell these to patients at $2,997 for these lasers. It's a 30-second treatment. They put it on the inside of their leg for 30 seconds, outside of their leg for 30 seconds, on the bottom of their foot for 30 seconds. They do that with each foot. Okay. This is going to dilate their capillary beds, activate nitric oxide, get blood flow to the tissues, and then you use as well, you start activating these platelets, and you're going to create angiogenesis. Nothing is going to heal till you get blood supply to it. All right. Vascular endothelial growth factors, VEGF, induces new blood vessel. There it is again. So we've got angiogenesis and the VEGF. Endodermal growth factors at the site will promote healing. And here we go, nerve growth factors. Thank you, AKA neuroplasticity. All right. So these are the things that actually happens when you inject this accelerated growth factor into the leg or into the body. Okay. Remember, it's L4, 2 areas at L4, the medial side of the leg, and L5, lateral side of the leg. And I gave you the picture on that. And again, and I give this handout to patients so they know exactly where the injection sites are. Plasma solution approach of accelerated growth factors provides effective in treating neuropathy and bone and joint conditions. The only published study with the first generation produced which has been enhanced, and it states that diet, exercise, rest, and accelerated growth factors, that combination is like, again, what I call the trifecta. I think I went through 4 different things, but we use the 3 different aspects of 7-point brain body gut exam, treat what you find. We do metabolic care, and we do regenerative medicine through platelet growth factors. Each accelerated growth factor syringe is certified to meeting the USP monographs. So they already have a lab and all of that. So you need to talk to Will and James about exactly all the specifications that they have with that. If you're going to get into regenerative medicine, I mean, in my opinion, this is the most cost-effective way to do it. Okay, you can do knees. You need 3 syringes. The vials are preloaded. and you do a single spin. And I mean, it's extremely easy to get started in regenerative medicine using plasma solutions. And if you don't know how to do it, I know a lawyer that can get you set up for your business. I mean, all your bases are covered with this if you're not sure what to do. That's why I'm here. This is why Will's here. This is why James is here to help you through to navigate all of this. All right. And again, it says here that that we have super dose of growth factors, super recruitment of stem cells, blood-borne stem cells. And then remember, the blood-borne stem cells, they're as powerful at any age, as young or old. That's extremely important. Growth factors of stem cells in high enough concentration promote growth of specific types of cells, accelerate development of new blood vessels. So again, that's going to be key. And so we have accelerated activation of and gives the purpose to native stem cells. So it's going to activate native stem cells, accelerated stem cell recruitment, blood forming cells, routinely used, we'll skip that part, as able to form new kinds of cells, differential, so they can differentiate into, do you need nerves? Do you need tendons? Do you need muscles? Do you need more blood vessels? What do you need? Muscle, blood, bone, tendon, ligament, cartilage, nerves. There you are. Okay. That's the differentiation. Okay. Simple injection techniques, L4, L5 dermatome. We've already talked about that. No need for imaging. You don't have to go in and you don't have to have any type of specialized imaging to make sure you're hitting the right spot. L5 on the lateral side, L4 in the superior aspect, L4 in the inferior aspect. Simple to do. We have no imaging except for radiographs in this clinic that we use. And in our clinic, typically, again, on the fourth treatment, patients are already seeing results. Now, L5, 4L5 dermatome, there we are again. And they're going to be using a 18 gauge syringe needle. You can keep it in the centrifuge after it's spun down for 30 minutes, but we need to get it injected within 30 minutes after that. And the way it works is we usually will be able to get, once we do all the blood draw and we spin it down, typically we will get about 9 cc's of accelerated growth factors. So 9 cc's. So you've got 6 injection sites. So our medical doctor will take 1.5 cc's per injection site, and then that's the magic number. That's how it works. It's 1.5 cc's per injection site for a total of 9 cc's. So in conclusion, the growth factor treatment is highly effective in treating a wide range of musculoskeletal injuries and conditions. Activation and aggregation play a vital role. We are actually enhancing the body's own ability to start aggregation. So again, we're using the body's ability to heal itself. All right. The spin protocol is important. The better the spin, the healthier the platelets and the growth factors. Peripheral blood-borne stem cells are affected at any age. At any age, that's extremely important. Stem cells and tissues that near the site of injury are metabolized. So you got mesenchymal stem cells. We all have mesenchymal stem cells. If we didn't, we'd be dead. Okay, and it's going to draw those mesenchymal stem cells into the area of damage. Okay, one of the things I would recommend too is it is recommended that when you do regenerative medicine, people have to get off their anti-inflammatory medication for at least 48 hours before doing the injection, because we want that inflammation in those areas, because that's kind of like the homing mechanism that gets the platelets and stem cells to come in and actually start repairing. Accelerated growth factors can be used to aggregate embryonic stem cell treatment, and accelerated growth factors is excellent standalone treatment for those wishing to use the patient's own stem cells. So that's in conclusion. So again, contact Will. I gave you that information. You can contact James. I've used this product since 2017 with phenomenal results. I've written 3 #1 best-selling books. These patients in these books have used this protocol. I'm not saying every one of them has used accelerated growth factors, but a lot of these people in my book, in these books that I've written, are using the accelerated growth factors. Now, in closing, let's talk about managing the patient's expectations. All right. So the science is there for the accelerated growth factors. And that's the part that I wanted to go over with you from their PDF. I apologize, we didn't have it on a PowerPoint. Now, the reason that we want to do the OPQRST appropriately is we want to, because we know that patients are going to have questions about money, they're going to have questions about time. Let's get for real. We live in the real world here. I take all kind of academic classes, but in academia, they don't talk about money except for when you have to send them a check to get to the seminar. Outside of that, they don't want to talk about anything about running a business. I love talking about how to run a business because I run a business. I am an entrepreneur. I change people's lives every day. All right. Now, with the OPQRST, we've got to ask those questions again. How long have you had it? What is the describe the symptom? All right, take your pointy finger. Does it start in the back and go down, or start in the feet and come up? And then who has helped you? Tell me one thing that you've done that's gotten help with this problem. And the answer is going to be zero. Now, again, when it comes to pain, sometimes patients might say, well, I got a steroid shot 6 years ago and the first one helped, but the rest of them didn't. Okay, that's like a crack addict. It's like the reason a crack addict keeps getting crack is they're trying to get the original high. And it's like the same thing with steroids is, and again, I only see the worst of the worst. So a patient, the best case that I've seen is a patient gotten results with the first one and none of the rest of them worked. All right. Some of these patients are already, remember, half of America is insulin resistant. So, and whenever you take steroids, it's going to boost, it's going to increase, not boost, that's a positive term. It's going to increase your blood sugar. It's also going to suppress your immune system. A lot of patients actually know that. So see people that are on that's diabetic or insulin resistant, they can't actually, morally and ethically, get a steroid shot. Sometimes it doesn't matter because their insurance pays for it, and the doctor's like, we're going to hit them with it anyway. I see it not every day, but almost every day in my clinic. So who's helped you? Name one thing that's helped you. Nobody's helped you. How many doctors have you been to? 3 or 4 or 5, whatever the number is. All right. What number are you right now? 10 is you're in a wheelchair. 1 is you don't have any problems. Where are you? All right. They're going to give you a number. Where do you see yourself 9 months from now? How that 9 months from now person, how that going to impact your life with your family, your kids, and your grandkids? How devastating is that going to be to you is what I want to know. What number do we need to get this to be happy with the results in the clinic? And then I also, which I forgot to ask you, say earlier, this is important. Tell me the one thing that you were hoping to get out of this meeting today. Okay. And I swear to the good Lord, if my hand was on the Bible, I'd tell you exactly what I'm telling you right now. And that is, there's absolutely no way, you never know what's going to come out of somebody's mouth when they say that. I have a lady that was here and she goes, well, the reason is what I want to know is, can you help me when I go to Birmingham and I see my grandkids? It's like I cannot function for the rest of the day when I'm there. I want to have energy. I want to be able to help them. And I'm like, it's going to be my goal to help maximize your recovery. Is that what you're looking for? And she said, yeah, I just shake their hand. I go, that's my goal too. But see, again, we're on the same page here, right? So now we have some ammunition. We know why the patient in here. We know what their outcome is, all right? What number they need to get, they want to get that'd be happy with the results. Most of the people are going to say 2 to a 3, all right? Now, when we go through the report of finding, and I go after we get through the neurological exam, which I told you how to do that, once we get through with this, then I'm going to go through and tell them what the program is. I don't use the word cost. This is going to cost you $15,961. This is an investment in your life. Now, before I have a patient even get a chance, and I'm about to close this in 5 minutes, before I even give a patient an opportunity to even say anything, and I say it's $15,961, then to start with, before I go over this, you may not be able to afford this, okay? And I tell them this program is $15,961, and I'll repeat it. You may not be able to afford this. You may not see the value in this. You may not see yourself as worthy of this. I don't know. I've literally had patients sit there and go, money is not even an issue, okay? Because see, what I did is I beat them to the money punch, okay? I told them that, you may not see the value in this. You may not see that you're worth this. You may not be able to afford this, okay? So what I do is I know money's going to come up. I mean, ever how many new patients you have today, money's going to come up at some point. So all I do is beat them to the punch with that, all right? And I go, if you see the value in this, this is the program you need to do. This is my best recommendation. And if you don't see the value, you can't afford it, or you don't see that you're worthy of this, I can give you a drop down option. Okay. So again, that's the program that I use, and that's how I set patients up with accelerated growth factors. I hope, guys, I hope that this helps you out. I don't know what questions we have. If you have any questions, if you would, if you want to, you can actually, I have my headphones on right here, or I'll take this off. If you have any questions, please just unmute yourself and ask the question for you. I'm going to open the floor up for just a couple of minutes for that.